Hello and welcome to this evening's Beckly Lecture. We're going to be starting in just a few minutes. Why don't you use the chat to introduce yourself and say where you're coming from. Hello everybody, you're very welcome this evening. We're going to be beginning the Beckly Lecture in just a few minutes. Do introduce yourself through the chat function. It's lovely to see all these greetings coming in from all over England, Scotland, Wales, indeed from all parts of the world. Do keep saying where you're coming from this evening, and we're going to be beginning the Beckly Lecture very shortly. We're just going to wait for the final few people to join us, and then we'll be beginning tonight's Beckly Lecture. We're going to be starting in a couple of minutes. I love it that people are telling us where they come from, what denomination they are, and that Tunnock's tea cakes are made where they live. That's reminding me I've not had any pudding this evening. We'll be joining you in a few minutes. Just waiting for the final few people to join us, and then we'll make a start on this evening. Good evening, and welcome to the Beckly Lecture 2021. As usual, this Beckly Lecture is taking place as a fringe event of the Methodist Conference, which is meeting in hybrid form in Birmingham. I'm delighted to welcome members of the Methodist Conference, which is the decision-making body for the Methodist Church, and also many other people who've been able to join us online because the lecture is happening in this way this year. In fact, this is probably one of the largest attendances we've ever had for a Beckly Lecture, and it's great to see the range of places that people are joining us from, and also the different denominations that people are here from. My name's Rachel Lampard. I'm a former Vice President of the Methodist Conference, and I've also recently been seconded to lead the Walking with Micah project, which is helping the Methodist Church to explore what it means to be a justice-seeking church. The Beckly Lecture is 95 years old this year. It was established originally as a way of helping Methodists to reflect on the social implications of Christianity. And it's continued as a forum ever since to help Methodists and others to engage with leading thinkers and speakers of the day, reflecting on current issues, be they political, economic, or social. As this is a webinar, your face and your voice won't be heard, so don't worry if you're still eating your tea. But you will be able to join in the conversation after the lecture. The lecture will last about 30 minutes, and then there'll be about half an hour for questions afterwards. Now, please use the Q&A function on your screen to ask the questions, not the chat. And don't feel you need to wait until the end. If you've got a great question, ask it. Now you've had a chance to say hello, we're going to switch off the chat function, as it can be rather distracting to participants during the course of a lecture. But please do tweet about the lecture, tweeting us at Public Issues and using the hashtag Beckly2021. This lecture is being run by the Joint Public Issues team. For those of you who don't know JPIT, we are how the Methodist Church, the Baptist Union and the United Reformed Church, working together with the Church of Scotland, work together on issues of justice and peace. And this lecture is an example of this kind of ecumenism at work. Our lecturer is a Baptist, and we were introduced to him by our colleagues in the Church of Scotland. Indeed, I think the recently installed moderator of the Church of Scotland, Lord Wallace, may be with us, amongst many other dear colleagues from the Church of Scotland and other denominations. You are all very welcome, and we are very much blessed being able to share in God's mission together. Which leads me to welcome our Beckly lecturer for 2021, Professor Jason Leitch CBE. Professor Leitch will be a familiar a familiar face and voice to many of you. As the National Clinical Director in the Health and Social Care Directorate and one of the senior team responsible for the NHS in Scotland, he's helped to lead the response to the COVID pandemic. He's been described as one of the most gifted medical communicators of the coronavirus pandemic. He's a regular on the media and on social media, and he's not been afraid to stand his ground against Piers Morgan and others and explain public health messages. Now, personally, I'm a fan of Radio 4's PM programme, and I must admit I always stop preparing the tea whenever I hear you're just about to come on and hear you in conversation with Evan Davis. He's a member of Edry Baptist Church, and Professor Leitch has also communicated in very authentic ways to faith communities during the pandemic. At the start of the first lockdown, he recorded a message telling churches they had to close, but reminding them that church in its broadest sense is open and required, necessary for society. So I hope you will rethink what it means to be church at this time, as communities, as electronic communities, and as families. He has a doctorate from the University of Glasgow, an MPH from Harvard, and is a fellow of the Royal College of Surgeons in England, the Royal College of Physicians and Surgeons in Glasgow, the Royal College of Surgeons in Edinburgh, and in 2011, he was UK Clinician of the Year. So I'm absolutely delighted to welcome Professor Jason Leitch to deliver this year's Methodist Conference Beckly Lecture on faith, leadership in a global pandemic.
Well, Rachel, aren't you kind? That was a lovely introduction. The only thing that put me off a little was, if I'd known Lord Wallace was coming, I may have put a tie on. I'm not sure how he'll feel about my slightly casual evening attire. I'm surprised there's anybody here. I'm not entirely convinced anybody is here, actually, because Andy Murray is one game away from winning his first round match. My mother, who kind of likes to hear me speak, is watching Andy Murray. She has chosen very wisely. And France, Switzerland has just kicked off. So if you have three screens and I'm in the middle, then maybe keep my sound on and watch Andy Murray win and perhaps keep me up to date with France, Switzerland. I hope we can engage you at least for the next hour or so. I'm enormously honoured to be asked, genuinely. I don't know much about Mr. Beckly, but I think I may have liked him. He appears to have been, in the little I've read and heard, a Christian with a social justice heart. And I think that's really important. I think it's very hard to live in a world with the social injustice that we face as a Christian and not think that might be part of your job. That might be one of the things you should do to serve the communities that are underserved. And that might be you as an individual, it might be your faith group, it might be in your job. Not everybody has all of those available to them. But I think, and we'll come to this perhaps in the lecture in a moment or two, I think one of the things the church has done in the round, and faith groups across the world, and not just in the UK, has stepped up. And I have views about whether we should hold on to that stepping up and what it should look like. Now I'm going to share my screen and we're going to go on a little bit of a journey around leadership in the pandemic. And this should now show you the first slide. Let me just make myself a bit smaller over here for me so I can see the slides. There we go. So this is a quote clearly about pandemics. The pandemic, which has just swept around the world, has been without precedent, etc., etc. More deadly epidemics, floods, famines. You could have read this in the Times this morning. Evan, as Rachel said, could have read it out on PM this afternoon. The funny thing about Evan, Rachel, is that I consider it my mission to make him laugh. He's not used to slightly flippant interviewees, and I'm very serious about the pandemic, but every so often, I try and get him to laugh, and I have occasionally managed it. But this is not from today. This is from 1919, the last time the world knew anything like this. This was the tail end of the Spanish flu pandemic, which killed tens of millions around the world. Unless you are 102, you've never known anything like this. It is completely unprecedented in the modern era. If you think it isn't, you've misunderstood. You haven't understood the scale of what this thing is. This is Tedros. Tedros is the Director General of the WHO, former Ethiopian Health Minister, and a wonderful human being. And when the music stopped, he was in the seat in charge of the world's public health. Probably the toughest job globally right now. 197 member countries, and trying to write the guidance and help and design what to do. He is fortunately one of the best public health thinkers in the world, and is surrounded by others, including a very prominent Irishman who does quite a lot of the press and the communications in an extrovert and blunt manner, which I admire for obvious reasons. And the WHO have held the ring for all of us on what this thing is, this thing that didn't even have a name last February. I mean, we didn't know what the virus was called because it had barely been discovered. And now, 48 hours ago, it had infected 167.5 million people and killed 3.5 million. 3.5 million. Now, more recently, Johns Hopkins University and The Economist did the first global study on excess deaths. So this is, in rough terms, and forgive the slight shorthand here, how many people have died beyond what you would expect. That's excess deaths. And the excess deaths cause for 2020 and 2021 is COVID. Of course it is. Unless you happen to have had an earthquake or a building collapse, tragically in Miami, or something else. But on the scale we're talking, the excess deaths are COVID. And the best estimate from Johns Hopkins is it's 10 million, 3 times the actual recorded death rate. So we think 10 million are dead because of this virus. And that could be anywhere from 13 million down to around 8 million. It is entirely without precedent in the modern era. So what should you do? Stay in bed? Well, some days, I can tell you, in the 15 months without a day off, it's been tempting. And I'm sure it's been tempting for some of you. Some of you have almost certainly lost loved ones. You may have nursed loved ones. You may have pastored loved ones, congregants, friends, family. I bet there's not many of you who haven't been touched in some way by this pathogen. So how should we respond? How should we respond as human beings, as Christians, as faith groups? What should we do as scientists? So this is my structure for where we're going to go. And I'm going to go through these in sequence. I'm going to try and say we should understand first, we should lead, we should step up, and we should hope. So let's do them in sequence. Let's try and understand what it is we're facing. So this is the grass market in Edinburgh. So many of you will know it. It's the social capital of a European capital. It's a half a mile from the castle and the Royal Mile. And it's afternoon tea and drinks in the evening and comedy clubs and hotels. It's exactly what you would expect. It's Scottish, so everybody's got a jacket on, as you can see. But it's a bit raucous at 3 in the morning. It's a little more quiet at 3 in the afternoon. This is it on an average spring, autumn afternoon. This is it in April 2020. We did this. We did this as a government, and 194 countries did exactly the same. They told their citizens to stay at home, completely without precedent. We closed the schools for the first time in history. We closed the civil service buildings for the first time in history. We shut hotels, we shut pubs, and we did it because we didn't know what else to do. That's the truth. Nobody knew what to do. Now, social media knows what to do, of course. Social media has certainty and direction. And if only we had done, the truth is, when the public inquiry and the histories are written, last March, nobody knew what to do. And even now, 15 months in, a brand new pathogen about which we learn more every single day, we're still not entirely sure what to do. You cannot be sure what to do. It is impossible. So we buy ourselves time. And that's what lockdown number 1 in the UK, that was from around the 23rd of March, although we had stopped large-scale events, we had shut schools, we'd done a host of things in the 2 weeks leading up to that. Other countries locked down a little bit sooner. Other countries were slower to do that, depending on their curve of the pandemic. And we bought ourselves time to try and think about what to do next. How are we going to get out of this unexpected pandemic? We all expected a pandemic. Every country in the world had pandemic at the top of the risk register. Every country in the world thought it would be flu, and it isn't. It's coronavirus. It's a respiratory coronavirus, unexpectedly. The WHO didn't expect it to be a respiratory coronavirus, nor did we. The WHO pretty quickly came out with the framework that you should use to tackle what you should do. And we're not going to go through these in any detail. And you could kind of write them yourselves now. You're probably mostly amateur epidemiologists. Some of you may be professional epidemiologists. So number one is control the spread, control the incidence, get the numbers down, the case rate down. Number two is test and protect. English, test and trace. Scottish, test and protect. Find the positive cases, isolate them from other human beings. The oldest public health intervention in the world. You can read about it in the Bible. We did it for leprosy 2,000 years ago. We did it for cholera 100 years ago. And now we do it for COVID. Find the infected individual and isolate them from the community. It's the oldest public health intervention and the best public health intervention in history. Number three is control outbreaks in high vulnerable settings. That depends on the pathogen. If that's measles, that's children. If it's COVID, it's care homes and prisons and children homes. So isolate and save as many as you can inside your institutional settings. Number four is workplaces. So that's where physical distancing, alcohol gel. So start to make them safe. Initially close them until you know what to do. And then as you bring them back, now some couldn't close, remember. It turns out there's quite a lot of essential services to keep the lights on, to keep the milk flowing, to keep the supermarkets open, and to run a health and social care system. So you need to make them as safe as you can. Number five is travel. We might come back to that in the questioning. That's import and export of cases. Don't import cases and don't export cases. Crucially, in the media version of number five, we only ever talk about import. We only ever talk about the risk of people arriving in the UK. Actually, export is a massive risk too to other countries. We have given other countries Alpha, which is the Kent variant, remember. And we have imported Delta, the Indian variant. But we're now exporting Delta and giving that to Western European countries who are probably 6 weeks behind our third wave. And number six, where I've spent quite a lot of my time, and that is engage your communities. Try and take the public with you. Now that's an intriguing and complex phenomenon that we need more time to do. But right at the beginning of this, the First Minister had a very small meeting with a number of advisors, and whether you like her politics or not, you can't argue that the woman is sensible and smart. And she decided that our communication had to be political and clinical. She had to be the key voice, of course. She's the leader of the country. She's elected. She's, I am not. Nobody voted for me, fortunately. But she realized she couldn't do it by herself. And we had to, as much as possible, have a clinician beside her. And that's what we've done ever since. There will be a First Minister's briefing tomorrow. And Gregor, my colleague, who's the Chief Medical Officer, will be standing beside her. There will be one later in the week, and I will stand beside her. We did that entirely deliberately. Now, the problem is, with all of that, what should you do? How should you think about this problem? Well, the exam question the First Minister comes to us with, or the Prime Minister goes to Chris Whitty with, is to reduce death from coronavirus, but it's more complicated because to reduce the non-virus harms to the population are as important as that virus harm, and to keep health and social care staff safe and supported. So we in Scotland have used a 4 harms framework for that, and it's worthy of a little bit of thought before we go a little bit faster. So we have tried to think of the problem we face through this lens. Now, all frameworks are wrong, some are useful. All frameworks are wrong, some are useful. So harm number 1, COVID harm, direct misery, death, destruction from the virus. Pretty easy to understand. Harm number 2, health and social care harms, not related to the virus, but related to what you do to prevent harm number 1. So that's waiting times. That's people like my father having his cataract operation cancelled at 80 years old. That's people waiting on mental health waiting lists longer than we would like. It's GP practices, dentists not able to see people face to face. Social harm, so the loneliness of elderly people, the schools being closed and disruption to young people's education, loneliness of huge swathes of the population. And that links to economic harm, of course. Economic harm, the direct economic harms of what you do, the loss of businesses, the doubling of the unemployment rate, the people actually losing their marriages, losing their businesses, losing their homes, as a direct consequence of what you do in your response to prevent harm number one. Harm number one has to be the principal harm. They're not equal, but you have to then, as you decide what to do and as you decide on your advice to the First Minister or whoever's running your country, or Emmanuel Macron or Joe Biden, you have to give advice that takes into account all these elements. And that's what we've tried to do. We have people in charge of each of the harms. So the chief economist is in charge of the economic harm. The chief social policy researcher is in charge of the social harm. And Gregor and Amanda and I, the chief nurse, the chief medical officer, and I are in charge of harms 1 and 2, the advice. We're not in charge of the decisions. We give that advice and the elected decision makers get to choose. So these are our weapons against those harms. And then we're going to have a little quick run through some data of those harms. Now, 2 of these have pretty much not changed. 2 of them have. So test and protect, our version of test and protect, find the case, do the test, protect them from the community, isolate them. That is pretty much the same as it was at the beginning of this, although we have much better technology. Non-pharmacological interventions, distancing, hand washing, closing down businesses where lots of people were gathered, keeping people, all of those things you've grown to know and hate. And then healthcare for infected individuals, that's got a lot better, but still we don't have good treatment for this infection. We can't treat mild cases and stop them progressing very well. We've got some steroids, some oxygen therapy, but nothing dramatic to help us. But the dramatic game changer is vaccination. We may come to that in the questioning. The most remarkable scientific discovery at the tail end of last year. And then in Scotland alone, 6 million doses in 5 months. 6 million people given a vaccine, 6 million injections, about 3.5 million people individually given vaccines in the last 5 months. So let's quickly do those harms. This is harm 1. This is death data, I'm afraid. This is mortality in Scotland. And you can see very clearly the 2 waves, the very, very high peak of wave 1, then peak 2, which was split over 2, and then now very high case rates, but not high mortality, because vaccination is protecting us for now from the worst. This is hospitalizations. Again, you can see, but hospitalizations in wave 3 just beginning to tick up, and that's beginning to worry us just a little. Harm number 2, this is a paused, postponed care. So grey is the average in 2018-19 for emergency admissions and planned or elective admissions. Dark blue is what happened during wave 1 and 2 of the pandemic. You can see how many fewer operations we did. So that's people waiting on waiting lists to be done because we needed the space for COVID. Harm number 3, remember, social harm. This is children at school. Pretty much less than a fifth, less than a 10th for primary. So the blue line is all kids. So if you look at the blue line, that's about 6 or 7% of kids in school from January through February. Then we open schools a little and we get up to about a third of kids in schools. That's huge social harm, particularly for those from lower socio-demographic backgrounds. Then there's the loneliness, particularly for those who were shielding, those who we said, don't go out. That was our instruction. Stay at home. Don't do anything. Don't go to the shops, get your food delivered. Don't see friends, do it by Zoom. That's hard. And people, of course, didn't have as much physical activity. Their mental health suffered. And then this is moving into raw economic harm. This is those in Scotland who are claiming benefits. And it doubled during lockdown number 1. Now, that is not just an economic harm. That's a public health harm. That is people struggling to put food on the table, struggling to dress their kids, and potentially mental health and physical health challenges. So I'm in no illusion that in the round, this is a public health challenge. So I'm sorry to be slightly depressing, but that's understanding the pandemic. Now, we haven't touched on what's happening right now. We might do that in questioning, but let's think ahead a little bit. So what should you do as an individual? This is Homer Simpson. Some of you will recognize him and his brain. To tell you the truth, if you don't have imposter syndrome when you're in the room with the First Minister, you have misunderstood the challenge. So this is sometimes how it feels for all of us, no matter how long we've been doing public health or epidemiology or trying to work out what to do. If you can't admit that this is sometimes how it feels, I think you're probably lying, either to yourself or to everybody else. But there are some things that help us, aren't there? And my proper job is the National Clinical Director of the health system. I'm a dentist who then did head and neck surgery for 15 years and then went and did a public health degree in the States. And one of the organizations I work for there is an organization called IHI, the Institute for Healthcare Improvement, the principal systems improvement organization in the world for healthcare. And they have loads and loads of fantastic work. And one of the things they have is a thing called their high impact leadership behaviors. Long story short, they went around all the high performing health systems in the world, interviewed the leaders, interviewed the staff, came up with how you should be. How should you behave? Not the organogram of your structure, not the governance processes, but how should you behave as an individual leader? And I quite like it. It's not perfect and it misses stuff out. Of course it does, but I quite like it. And these are the 5 behaviors. Now, I've tried to use these behaviors in my normal leadership to be a surgeon and to be the clinical director of cancer care and all the things I conventionally have to do. But in COVID, the equation changed a little. So person-centeredness, instead of being patients and families, became stakeholder groups. So I've spent huge amounts of time with the Scottish Football Association. There are 500,000 people engaged in grassroots football in this country. 1/10 of the country are involved in grassroots football. You might cook the pies at half time, you might play, you might be a young lady who referees. There's huge numbers. So if you can get to those 500,000, you can get your message out very, very coherently. I've spent a lot of time with those who may be more at risk of the disease. So HIV Scotland or the Scottish Partnership for Palliative Care, you get the idea. So be next to the customer, understand where that customer is, whether it's a patient and a family or whether it's a stakeholder group that you might need. The second behavior is frontline engagement. So I am used to spending my time in clinical practice or communities and podiatry and dental practices and hospitals, and trying to understand what the frontline are doing and then try and give advice that's appropriate to that. But my frontline changed dramatically. I've now been in electrical substations and buses and trains, and the entertainment industry and soft play and everything that's still closed, I'm afraid, still hate me. You just need to look at my social media. It's not particularly pleasant, particularly today, actually. But I've tried to spend time in these environments to try and understand how we can make them safe and try and engage with them. One of the things I've done is the faith leaders group. The faith leaders in Scotland meet every couple of weeks, including the Methodists and the Baptist leaders. And we as a group have tried to help them with advice, with understanding of what the restrictions are, and I've tried to play my part in that space. The third behavior is relentless focus. And relentless focus in my normal job is that constant rhythm of trying to improve the system. Here, it's been about communications. And I apologize to the Scots who are fed up hearing me on the drive time show in the evening or the morning breakfast programs with the news or at the briefing with the First Minister. But our idea and the communication professionals tell us that we have to keep that focus. We have to keep selling that message again and again and again. Transparency is the fourth behavior, and that's about telling the truth. That's about, at the time you say it, make it true. Now, that doesn't mean the truth doesn't change. Of course, the truth changes. The story changes. You can find interviews from me last March that now sound stupid. And I'm quite sure interviews I gave today will sound stupid another year from now. And that's, the media can play that mischief-making game. I'm sure there are some here, particularly Lord Wallace, if he's available, will testify to the media being able to do that. But at every moment where we've stood there and told the truth, we've tried to do it with the best of intentions. We've also published as much data as we possibly can. We have a dashboard in Scotland now where you can look at very, very low-level data in your neighbourhood. It's also available in other parts of Britain. but we've tried to give as much information as we can. And then the final behavior is boundarylessness, a made-up American word. It doesn't actually exist, but you get the idea. And it's about that broad approach. We couldn't have had a response without politicians, but also with the third sector, and using the media, and health and social care leaders, and businesses, and police, and the people of Scotland. We do polling every week. We try and adapt our story, our comms, to what the people of Scotland are feeling and experiencing. We try and take them with us as much as we can. That's not always easy. We've had to restrict people's freedom beyond anything anybody would want to have to do or advise. But in the main, the country has come with us. We're in a very interesting spot now with high cases, high vaccination, and a lot of people are fed up, including me, to be perfectly honest. So those are the 5 behaviors. That's lesson number 3, I think, is lesson number 2, rather, is to lead. So understand, lead. And my third and final quick lesson is to hope. And I think it can be easy to despair. You could look down this tunnel and presume that the light at the end is a train coming to get you, because it is the gift that keeps on giving, this virus. We've now opened twice in this country, and twice we've got a new variant. That's not been to do with the opening. It's been coincidental to the opening, but it has therefore set us back. And it can be hard. It can be hard to be a family on the 3rd round of self-isolation. It can be hard to be a business owner and watch your savings have to be spent on that restaurant or bar or gift shop. And it can be hard, frankly, to be at the supermarket checkout or the customer service desk when people are shouting at you for not wearing a mask, or you're shouting at them for not wearing a mask. And health and social care staff in particular are tired beyond anything they've ever experienced. And yet we ask them to do more and more because we have to. There are people waiting for life-saving cancer care. But I think inside all of that, there is hope. One of the things I've grown to love is the ability I've had to go visit and see people who have stepped up, community groups, church groups, mosques, synagogues, boys' brigade groups, and football clubs and others, to find a hope in that community-based approach. One of the things has been to keep the kind of the emergency elements of our system in place. My wife is a teacher, a high school teacher of English as an additional language to refugees and immigrants in Scotland. And she worked from home for a little while, then quite quickly was back out in the community teaching in schools. And teachers all over the country, support staff, teachers, classroom assistants, and learners, of course, have been in that world. One of my great pals is customer service at ASDA at a desk. And if you think that isn't the front line, then she would swap with you. It is very much the front line. But I think we've learned quite a lot about well-being, about joy in work. One of the things we did in health and social care is we built field hospitals. You can't have missed them. The Nightingales across England and Wales, and the Louisa Jordan in Scotland at the SEC, at the big conference centre. They were astonishing endeavours, absolutely astonishing endeavours, and huge amounts of work. And loads of people came forward to help us. So everybody got free coffee when they arrived in the morning. The Lindt gave us more chocolate bunnies than you could ever give out. Moisturiser from John Lewis, fizzy drinks, although the dentist was a little unhappy. And a young man in the top left who did fitness classes at the London Nightingale, and we streamed them to all the other field hospitals around the country every morning so that people could join in and do their exercise class once they got to work. Now, this is fantastic. It's terrific. People felt they belonged to a family. They felt as though they were part of something huge, whether they were the armed forces or the security guards at the Louisa Jordan or the doctors and nurses who manned the beds. What strikes me, though, is that Glasgow Royal Infirmary is 3 miles from the Louisa Jordan, and we didn't give them Lindt bunnies, and we didn't give them free coffee when they arrived in the morning. So we can do it when we kind of take the initiative to do it, but we didn't do it for everybody else. We clapped and we sent rainbows and cards, and that's absolutely terrific. But I think there's something to learn about well-being and joy in work, not just for health and social care, but for the broader community. This was to remind me that hope is not always everything that you need. You actually also need practical experience, and you need to make it task-oriented. So this is the hope we had in the Euros, of course. This is Scotland qualifying for the Euros. And I don't need to perhaps tell you how that ended for us. Although, lots of hope, young team, did well, hopeful for the future, and I look forward to following them for years to come. So that's hope in us, but I couldn't give the Methodist Beckly Lecture without thinking a little just at the end about the greatest hope, the greater hope than having to rely on a hope in each other. And you don't have to go far to find in Paul's letters that hope. We rejoice in the hope of the glory of God, the greatest hope of all. Now, I think my reading of Scripture, Jesus's life and God's instructions to us, is that we should live with a social justice conscience. He hasn't decided to leave it all to him. He's chosen us to help in that social just world. And I think that means lint bunnies and coffee on the way in and pastoral care of those who are dying in our hospitals of COVID and anything else you want to direct that to. But in the end, the end is hope in that God. But as for me, I watch in hope for the Lord. I wait for God, my Savior. My God will hear me. Micah 7:7. So I've tried to give you some level of what my life has been, a little bit, some reflections on what that system and job has felt like for the last now 18 months of this journey. So understand the challenge. On this occasion, it's the pandemic. Lead, so step up. Don't wait for others. Lead yourself. And that framework might help you a little to decide how to lead. And then hope. Hope both in us as individuals, faith groups, the broader community, the boys brigade, whatever it is beside you, and that eternal hope, that hope in our Saviour and our God. But maybe right at the end, if Doc in Back to the Future ever asks you where you should go, then I think his advice is good. Marty, whatever happens, don't ever go back to 2020. Thank you very, very much for listening. Rachel.
Jason, thank you so much. That was quite a tour de force. That was half an hour that had passed extremely quickly. I'm very grateful for that indeed. We've had some questions coming in, which I will process. But one thing I didn't tell you, Jason, before we started, was I'm actually under quarantine at the moment. I have 3 COVID-y children at the moment in this household. Yes, exactly. So I just wanted to start with one question that was about devolution and the impact on test and trace, or test and protect, as it is in Scotland. I experienced the multiple phone calls from test and trace this week. Do you think our efforts to try and control the pandemic through test and protect, test and trace have been hindered or helped by devolution?
I think they've probably been helped. I would say that, of course, wouldn't I? But we have had very, very collegiate clinical advice. So every Tuesday night, the 20 or so senior clinicians in the 4 UK countries meet. And we've met, initially we were meeting twice a week for a couple of hours. Now we meet once a week, sometimes once a fortnight on a Tuesday night. The CMOs, the CNOs, the people who do my job, and the public health leaders, 16 to 20 of us every Tuesday. And we answer questions like, what should we do about self-isolation? What are the trials telling us about the Delta variant? So the clinical questions, not the judgments, because the judgments are for others. They're not for us. So what to do about travel is not a question for us. The clinical advice about what to do about travel is a question for us. And we've tried to do that as much as possible together. And I think that has served us well. Now, when we then take that into the 4 countries, then the governments elected in those institutions get to make those choices. And they have been a little bit different. I think some of the differences are exaggerated. So there's sometimes a difference of a few days. We closed our schools first. We opened them earlier. Some people have done, yeah, it's varied a little. England in the round has probably had faster relaxations. Scotland has had the lowest case rate throughout the whole pandemic until very recently. And now probably Scotland is paying a little bit of a price for that because we have less immunity in our population than other parts of the UK. So I think the politicians have made some different choices, but in the main, the clinical advice, for which I am part and partly responsible, has been joined together.
Thank you. We've had two questions that have come in. One from a hospital chaplain who has expressed concern about the mental health of staff. Which says that staff are beyond exhausted and we're back to business continuity with restrictions on annual leave. And she asks what provisions are being put in place to help and protect and support NHS staff. And then a GP has asked, how can we renew community support and give hope to key workers, as he says, who are currently experiencing increased levels of abuse from unhappy patients and customers who are fed up waiting for procedures, as you described with your own father. So two experiences there from a hospital chaplain and from a GP, both concerned about the impact directly on the NHS.
Well, you won't be surprised to hear I don't have a magic answer for either. I wish I did. The chaplaincy services across the country are one of my favourite pieces of the puzzle. I love the Scottish chaplains, and I spoke before the pandemic at the UK Chaplains Conference. It was a terrific occasion. They are the unsung heroes, one of the groups of unsung heroes in our COVID response. They've been absolutely fantastic inside the service in really, really challenging circumstances where they have to put themselves and their loved ones at risk, of course. And our GP community, not to be glib, but the front line often of our medical services have had to completely change the way they work. They've had to think very carefully about the safety of their staff, themselves, their families, and those they serve. So you're right, with the well-being of staff, the annual leave, the mental health challenges, the addiction challenges, everything else that's going on there needs to be a big, big priority. In Scotland, we've announced £8 million this week for a wellbeing fund to extend some of our initiatives that have worked really well. We need to do that along with the communities we serve, so we can't do that top down. We need people to help us with that. The UK government is doing very, very similar things, but there isn't a magic answer, and it will need to be hyper local. So people will have to get alongside the very, very small groups, the clinical teams, those who have been in the front line of this fight for a long time. I went on a visit to a hospital a couple of weeks ago in Scotland, in my hometown actually, where I was brought up, and I met a very young care assistant, a young lady who was working in infectious diseases. The infectious diseases in this hospital, pretty much no deaths pre-pandemic, because in the 21st century, most people survive infection. So they had no deaths. And in 2020, they had 88 deaths. They had a death and a half a week in big chunks, 2 waves. And this young lady had held the hands of those who had died, and she wasn't expecting to have to do that. It was traumatic. It was horrid. It was incredibly challenging. And then as she was walking me to the canteen where we were having a bit of a reception, she told me that that morning, she was one of 18 of 200 successful candidates for nursing in a local university. And she had been completely inspired by the healthcare team around her and applied to do nursing. So she was going to go from being a healthcare assistant who had worked in infectious diseases to she'll be starting university just in the next few weeks to become a nurse. So there is joy inside that challenge, because the teams are in the crucible and they're working together to do it. But I don't underestimate some of the challenges we're storing up for the future.
That's encouraging to hear. Being a governor of a school, I wish I was hearing the same stories about teachers who've experienced a pretty rough time this year as well. It's a hard place to be, I think, in many times, isn't it? We've got some questions coming in about communication and social media, which has obviously been one of the things you felt particularly called to this year. We've had a question from the moderator, Jim Wallace, saying about you've mentioned your personal social media feed and the slightly less than friendly comments that you sometimes, from time to time, get on that. It asks, how do you deal with gratuitously unpleasant comments? And in public life, should we as people of faith ignore it, or what should we be doing to challenge it?
It's a good question. So it was new to me, completely new. I'd never experienced anything like it. So I went from 12,000 Twitter followers who all they cared about was healthcare quality and a little bit of person-centered care and patient safety. And I got a little bit of challenge sometimes from patients and families who had lost loved ones, for example, and I was a bit of a target for some of that, to nearly 100,000 followers in about an hour and a half. And most of them were not joyful. They weren't following me in order to wish me well. Many of them had lost their businesses. They were nightclub owners. And I was perceived to be the one who had shut their nightclub. I mean, that's hard. I mean, that's hard for them, not for me. I mean, I absolutely feel for the events industry, for those who have had to be last in the order of opening again. But my job, my authentic job is to give the best advice I can to protect 5.5 million people. If that's not my job, I have to step aside. Now, inside that, this is not meant to be glib. It might come across as glib. There's a lot of people working harder than me. So a shift in a care home or a shift in an intensive care unit is harder than being the national clinical director. I've got purpose. I've got a fantastic team of people around me. I've got a family that love me. I've got a house and a salary, and I'm not going to lose either unless I really blow it. But the direct abuse of me is tough on my family, tough on my mum and dad, tough on my wife who's a teacher. And Lord Wallace has probably had to deal with it much more than me. It's funny, it's maybe a longer conversation. The ones who are direct abuse, I actually can just ignore them. The ones that just call me names, that doesn't really bother me. They don't know me. There's no skin in that game. I don't really care what they think. The ones that get me are the low level, the ones who think I'm doing it because I'm bad, or they attack my motives. And it's kind of, you're a clown, you don't know what you're talking about, you're just in the pocket of the SNP. Or the opposite of that sometimes, you're just anti-SNP, you're a football fan, all that they just chip away at you. They're the ones that I find harder to deal with. So I stop looking is the tactic. So don't look at Twitter replies. Use Twitter as a way of informing, not of having dialogue, because it doesn't work for dialogue in the main. You might do it if there's an MP who asks you something, or a journalist who asks you something, and it's perfectly reasonable about. So somebody asked me today, what are the restrictions about outdoors because I want to take 12 people. So if it's a reasonable question, then engage in that way. But in the main, I try and ignore it, and I use it as a broadcast medium rather than as a conversation medium. And in the real world, people have been absolutely lovely. Absolutely lovely. I was out running a few weeks ago, and an elderly couple stopped me when I was stretching outside my house, having barely run. Of course, I'm a slightly middle-aged fat runner, so it's not far. And they had tears in their eyes, telling me how wonderful it was to hear me and how much I protected them, and they really appreciated everything I was doing. So in the main, people are exactly as you would expect. They are absolutely lovely. But there is an edge, particularly in social media, in the anonymous world, particularly of Twitter, that is nasty and worth avoiding.
And that's where you come across it, yes. We had another more general question saying, what's the experience of the last 16 months taught you about how you communicate?
That's an excellent question. So those of you who, the Baptists in the room, will know that every time I stand at the podium and I say, right, when the First Minister's done her thing, and I'll say, right, there are 3 things you need to know about this. So that's Baptist. That's just ingrained in me.
It's fairly Methodist as well.
That's my father. My 80-year-old father telling me how to communicate. So actually, I don't think church did me any harm. I think that it taught me to talk out loud. It gave me self-confidence a little. So I've been at the front of churches many times, and I can certainly talk out loud coherently. Whether you wish to listen or not is a different question. And I've also learned that you need different method to get the same message across. So, for example, if you want to speak to Orkney, there is no point in doing Radio 4. You have to do Orkney radio. And everybody in Orkney listens to the radio at 6 o'clock every night, because that's where they get the Orcadian news. That's the programme everybody listens to, because it's the local radio station. It's on Radio Scotland, but it gets divided up, and Orkney get a special version. So if you want to speak to Orkney, which we've occasionally wanted to do, I need to go do Orkney radio. If you want to speak to Oban, you need to be in the weekly newspaper, because everybody reads the weekly newspaper, the Oban Times. Where I live in the centre of Glasgow, nobody reads a weekly newspaper. There's no point in being in the weekly newspaper. So you have to, and there are communication professionals who know that kind of stuff. There's a science behind who should give the message and where you should give it and how you should give it. And that applies to the vaccination programme. So when you have minority ethnic groups who won't get the vaccine, sending the 52-year-old white guy is probably not the best tactic. You might use me a little bit for follow-up messaging or for Q&A of the science, but actually if you send Hamza Yusuf, the new Cabinet Secretary for Health, and Anna Sarwar, the Scottish leader of the Labour Party, to the mosque to do the communication, that's much more authentic than sending me to the mosque to try and do that communication. So I've been in slightly odd communication rooms where I wouldn't have expected to be, but we've tried as far as possible to use the mechanism that reaches the most people and trusted voices. You won't know, Rachel, that there is the most listened to radio show in Scotland is a football programme on a Saturday lunchtime called Off the Ball, and all the Scots will know it. And I've been on Off the Ball every week for a year. And that's not because I'm a big football pundit, although I'm happy to talk about football. It's because it reaches an incredibly hard to reach demographic of young men who don't listen to news programs. So if you want them to come for the vaccines and you want them to understand the state of the pandemic, you have to be on the football show.
Which is a lesson for us in the churches as well, isn't it?
Quite, isn't it?
Which is where we started this question. I wonder if we might move on to some questions now specifically about churches. I quoted you at the beginning saying that encouraging churches to kind of rediscover their role as church, and just because buildings were closed, churches weren't. Across Britain, across the UK, churches have realised a very particular role during the pandemic. As we are moving hopefully into this new phase, what's the next space that churches need to be moving into, having learned and experienced what we have done over the last 15 months?
I feel underqualified to answer that. I think you probably have more qualified people here, maybe even you, Rachel, but lots of others listening. I have views, and they're not dissimilar to the views I held before the pandemic. I think the pandemic has just encouraged me in some of those views. The churches that are growing and appear to be successful, whatever your definition of that might be, and that's a whole theological study of its own, isn't it? What success looks like, are in the community, of the community, but still have strong and basic theology. They believe what they believe, but they don't hanker after a version of evangelism or a version of community or a version of church that is 1950s. And I am relatively comfortable in a 1950s church in the round. I'm not uncomfortable there, but that's not church nowadays, I'm afraid. Those churches are dying. There isn't any question about it. The churches in Glasgow, where I live, that are succeeding are evangelical. They have strong theological basis, but they are in the community. The only thing we kept open in Airdrie Baptist was our food bank. That was the only thing in the building that worked the whole way through the pandemic. We moved everything online, and we've now gone back to face-to-face services on a Sunday morning with limited numbers. We've split the congregation in two, so you come on week A or week B, but we've got streaming now, we never had. We've got probably 4 times as many people at the prayer meeting on a Wednesday that we had in person. We've done Bible studies on a Sunday night with guests who I could never have got to come to Scotland on a random Sunday night to speak to 13 people in Airdrie Baptist, but they're speaking to 50 people online every Sunday night. So I think what we'll move into is, I hope, a hybrid version. I look forward to getting back to face-to-face worship, to be able to sing, to be able to see everybody. But I have a feeling that in our experience in Airdrie, we'll probably keep our Zoom prayer meeting on a Wednesday night. I think we might do it fortnightly rather than weekly, or I don't know. But I think we have to move a bit like the rest of society will into what that hybrid world looks like. And that's the organizational piece. The other piece is churches have stepped up. Churches have become known in their communities. And I really, really hope we don't lose some of that. So the Sikh temple in Glasgow is 5 minutes from my front door. And they, at one point in the pandemic, they were making 3,000 curries a day and taking them to households, lonely, elderly households all around Glasgow. And they've kept a lot of that up, that kind of community spirit, just people putting their phone numbers through their neighbours' doors. I hope church can be known for that. I'm a great believer in church being known for what it's for rather than what it's against.
Thank you. And can I just put you on the spot, seeing as we have you? Methodists love singing. Can you tell us when we're going to be able to do congregational singing again?
I can't tell you in England. I'm not sure of the English rules. In Scotland, the rules are that in level 0 and level 1, you can sing. So that means some of the country can sing already. Unfortunately, in my part of the country, we can't. The present plan, although it's a little bit ropey just now because the numbers are so high, that happens on the 19th of July. So on the 19th of July, churches in Scotland, all being well, if the indicative dates become true, and that will be the First Minister and the Cabinet's choice, not mine, we will all be singing in congregations on whatever the Sunday is after the 19th of July, and I'm thoroughly looking forward to it.
Great, great. Oh, well, I'm sure churches throughout Britain will be looking forward to their particular dates as well. You shared the very helpful kind of quadrant of the impacts of COVID, which I hadn't seen before, and it's a really helpful way of thinking about it. What do you think are going to be the biggest public health challenges that COVID will leave as a long tail?
So there's the disease itself. So we now know that COVID, just because it is the gift that keeps on giving, also gives a certain proportion of the population a chronic disease. Now, we're not quite sure what that chronic disease is, and we're not quite sure of the proportion of people who get it. But just now, about 0.5% of cases at 12 months are still experiencing symptoms. About 1.5% are experiencing symptoms at 12 weeks, and that gradually goes away, but you are left with a stubborn tail. Post-viral disease is fairly common. We're used to dealing with that. It's very, very difficult to diagnose and treat because it is so generic. It doesn't appear like a broken arm. It's much more difficult. And it's a very, very mixed picture of symptoms from person to person. It could be mental health. It could be gut. It could be dizziness. It can be all kinds of things. So it becomes really, really difficult to manage. So what we're calling it is post-COVID syndrome, officially. What the popular press are calling it is long COVID. So that's problem number one, long COVID. Problem number two is we're storing up masses of care that hasn't been treated. Dentistry, optometry, mental health, and normal hospital waiting times. Dentistry, for example, is a huge problem because we haven't been doing checkups, routine checkups for some time because you need to clean the surgery after you do drilling, aerosol generating procedures. So dentistry has stored up a whole load of challenges that will be a problem going forward. But we also have people on waiting lists for hips, knees, cataracts. The toughest thing is that quite a lot of people on waiting lists will have much more severe disease than they were referred for. It's just the nature of healthcare. And we will miss some stuff, and some stuff will present late. That's a huge problem. And you can't talk about the legacy without thinking of the mental health of the population. We're not quite sure what that mental health looks like. Some people have embraced it. Some people have found new ways of being, have had family and friends and Zoom and all of those other things, but that's not universal. There are people who have really struggled with lockdown and loneliness and being isolated from their communities. And that, I think, will be a lasting legacy that we'll have to deal with.
Thank you. One of the other quadrants is obviously around the economic impact, and the churches that I work with have been running a campaign called Reset the Debt, which has been highlighting the impact of COVID on household debt, and the fact that one in, I think it's 11 million people got into debt because of COVID, and 1 in 20 couldn't afford to buy household necessities because of COVID. This is a kind of a long problem that we're living with. Could you reflect perhaps for us on some of the links between the health inequalities that we've seen and the economic inequalities that we're witnessing?
Yeah, I'm afraid they are inextricably linked. Your best protection against COVID is wealth. It makes you less likely to catch it. It makes you less likely to be hospitalized by it, and it makes you less likely to die of it. It also makes you more likely to be vaccinated. It makes you more likely to have a job that doesn't require you to go to work, that you could work from home. Self-isolation is less of a problem for you if you're wealthy, because you can usually manage, or you will have an employer who will allow you to manage. If you are poor, if you're in the gig economy, if you have 4 kids and you're a single mum or dad in a high rise, that is all more difficult. Everything about that is more and more difficult. Now, governments have tried to step up all over the world and provide versions of a solution for that. Furlough is one such solution. Furlough is a very, very generous and a universal offer to most people, but it didn't cover the self-employed quite as much as some would have wanted. It didn't cover all of those Uber drivers and Deliveroo bicyclists and everybody else who lives in that part of the world. There are winners and losers always. I mean, if you were an Amazon driver, you've probably retained your job, but if you were a Deliveroo driver, you've probably retained your job. But if you're an Uber driver, for a long time, nobody got in taxis, and that still is true. Governments, on our advice, have tried to step up and do some of that. We have a fantastic chief economist in Scotland called Gary Gillespie, who provides our advice for Harm 4, of course, with multiple others, and the economic advisory groups and everybody else feeding into that. And Kate Forbes, who's our cabinet secretary for finance and the economy, effectively our chancellor, she is very, very passionate about business support, about what we can do for individuals. But it's a hard slog, and health inequalities in Scotland and in cities in England, particularly northern cities in England, pieces of London, are deep-seated and generational. And COVID has just exposed them once again. And if we don't think about that on the way out, we're going to have to pay that price for a long, long time. And we are thinking about it on the way out. People are talking about renewal rather than just recovery. And we will give the best public health advice we can in that space. But that's a broad set of challenges that are economic, that are criminal justice, that are educational. They are not just health. They have health consequences, but health cannot fix them by itself.
Thank you. We've had some questions in about vaccinations, and they tend to be from the kind of the global perspective. So I don't know if you feel happy kind of commenting here, but you can imagine with a Christian audience, that's probably going to be quite likely. The comments made, I think it's generally accepted that we're only safe from COVID-19 when we're all safe, when we're all vaccinated. With 2/3 of the UK population has had at least one dose of the COVID vaccine, but globally it's less than 18%. What's the public health implications of this inequality of the global vaccine rollout? Do you think that we should delay the booster vaccine, for example, or should we be changing patent rules around vaccinations?
So yeah, the easy one's the last one, yes. So we should make vaccines as available to the world as we possibly can, and any bureaucracy or private sector challenge that stands in the way, we should, of course, remove that. Let me just remind you, though, that we couldn't have done this without private partnership. It would have been impossible without higher education, big drug companies and governments working together. Now, we had to underwrite, as governments, quite a lot of the research so that we could build the vaccine plants at the same time as doing the final trials. The drug companies wouldn't have done that. So governments underwrote that in all over the world. But the partnership between private, public and third sector organizations have been absolutely crucial to get to where we've got to. The questioner is absolutely correct that we won't be protected until all are protected. There are a couple of illustrations of that. India, where I have a huge connection. I've been about 15 to 20 times to an orphanage that I help there with some pals who are Indian who have run it for years, a children's home and a college and a nursing school. And I go every year or two. I'm probably going to miss the trip in January coming. They have the biggest vaccination program in the world in India. They also have the biggest vaccine factory in the world. They've vaccinated, last time I looked, 170 million people. That's nearly 3 times the population of the UK, and it's 12% of their population. They need to vaccinate 1.4 billion people twice. They need 2.8 million vaccines, 2.8 billion vaccines. The numbers are eye-watering. The G7 promised 1 billion vaccines from the 7 countries, which is absolutely fantastic. And Tedros, the head of the WHO, gave a press conference the next day and he said, "Thank you very much. Where am I getting the other 10 billion from?" And he's right. He's absolutely right. And that will have to be a public-private partnership. COVAX is our mechanism, which is a partnership of vaccine companies, the WHO, funding. The UK is the second biggest funder of COVAX. Last time I looked, we'd given £750 million to COVAX, second only to the US, who, when Biden came, they hadn't given anything. And then when Biden arrived, they gave $2.5 billion to COVAX to buy vaccine and produce vaccine and get it distributed. Remember, this is not a simple problem. You can't just send Malawi the AstraZeneca vaccine you haven't used. The vial doesn't inject itself. It doesn't get to the villages by itself. You need logistics and infrastructure and people and instructions and communication and translation. And you need to deal with vaccine hesitancy in Ethiopia, just like you need to deal with it in Easterhouse. So it's not just vaccine, it's a vaccine program that has to incorporate all the elements of a vaccine program in rural Indian villages and Indonesian jungles, as well as getting them the actual vaccine. Getting them the vaccine is just step one. So it's a huge problem. We are engaged in Scotland as much as we can be. I don't think we're at the stage yet where us pausing would help that. It's an easy headline that let's not vaccinate children so that we can vaccinate Malawi. If I thought that was a direct choice, I would choose Malawi, but it's not a direct choice. I don't think we're at that level of brinkmanship right now where us doing something or not doing something would suddenly help Malawi get vaccinated. I'm afraid the problem is much, much more complex than that makes it sound.
Thank you for that. Thank you. And another tricky question that's certainly come up in England is that care workers are being told that they have to get the vaccine in order to continue in their frontline roles. Do you think that mandatory vaccination is a proportionate response?
So this is tricky. So this is tricky politically. So what I'm going to dodge it slightly by saying that the Scottish position is that mandatory vaccination is not the way to go for our community for 2 reasons. Reason number 1 is we have very, very high take-up. We have over 95% of our health and social care staff who have been vaccinated. In most areas, it's well above 99%. So we've got very, very few vaccine refusers in the health and social care staff. In fact, we've exceeded our initial target. The social care staff is a little bit hard to pin down because there's quite a lot of movement in the social care staff. It's not a fixed group of people. People come in and out of that workforce, and some of them are trickier to find. But in the main, Scotland has got very high levels of vaccination. That's reason number 1. Reason number 2 is behavioural scientists tell us that at our level, in our communities, that's not the way to get the last few stragglers. The last few stragglers would be better served if you go to them and communicate with them and surround them with good advice. There's a thing run by an American, it's an international organization called the Vaccine Confidence Project, which is a terrific website containing all kinds of information about what to do with vaccine hesitancy. And the principal lesson is go with trusted voices to the vaccine hesitant community and surround them with the correct science. Don't fight the vaccine skeptics. Don't fight the anti-vax community who are out to say it's all microchips and infertility and just scientific nonsense. Don't address it. Just ignore it. But surround the vaccine hesitant groups with legitimate questions and good questions with the correct information. And that's what Scotland has chosen to do. Now, if I were in a different community, if I were in a London borough where I had 50% vaccine and social care workers were not being vaccinated, I may well have a different view. So I'm not going to judge or criticise other parts of the country or other parts of the world who are making different choices. But for Scotland, our choice is no mandatory vaccination.
And for churches, for example, for communion stewards giving out communion?
So that's a different question. So that's a really, really good question. So should your medical history let you do stuff that other people can't do? That's a massive ethical question and not for public health advisors. I think that's a matter for politicians and for judgment. My view, perhaps a little controversial, is that some elements of society will almost certainly need your medical history to matter. So Qantas Airways have already said they will not take anybody who isn't double vaccinated or who isn't a child. So the private sector are going to be way ahead of us. They're going to decide. You can't fly to Israel just now unless you've had a double vaccination. France has just decided they will take UK travellers who are double vaccinated. Now, should nightclubs only let you in if you're double vaccinated, or soft play, or whatever sector you wish to choose? I'd be reluctant to say that churches should do it, but one of the things we didn't cover in the lecture, because I took it out because I knew I'd run out of time, is there is something about churches being responsible. I think churches should be responsible citizens. So I was very disappointed with churches suggesting that they wouldn't follow the rules. Now, they may disagree with the rules, and I'm very happy to talk to them about those rules, and I've done that many, many times. But to actively disobey the rules, I think is a very slippery slope, particularly when those rules are about protecting other members of the population. So I think churches should step up and they should advertise vaccination. They should run clinics if they have to. They should have vaccine literature. They should encourage those they serve to be vaccinated. Now, that's not a universal view. Other people would think that's ridiculous. They should stay out of it. It's freedom. People should get to choose themselves. I disagree. I think it is a selfless act that protects not only you, but those around you. And therefore, church should engage in it.
Thank you. Thank you for that. We've got time for two more questions. One is around groups of people who often don't get mentioned. So somebody has written a question about homeless people and the measures that were taken, certainly in England, and I'm not sure what happened in Scotland with the everyone in mechanism, trying to bring everybody in during the first lockdown and protect homeless people, and the question of what needs to happen next to that vulnerable group. And then a question from Andrew McClellan, who's the former Chief Inspector of Prisons, and I think possibly a former moderator of Church of Scotland as well, asking about prisoners, often a forgotten part of our community, and what the impact on prisoners and prison families and prison staff has been. So a question about two often forgotten groups during the pandemic.
They're two of my favourite subjects. So I spent a lot of time with both groups, and the seldom heard groups is what we generically call them. We did exactly the same thing in wave number one. If we tried, we don't actually have that many rough sleepers in Scotland proportionately, but we still have some, particularly in Glasgow. And one of my great pals, one of my great connections is Glasgow City Mission, one of the homeless charities. My wife worked there for a while teaching refugees English. That's where she got the passion for, she was an English teacher in a conventional school for years. And where she got the passion to teach English to refugees was at Glasgow City Mission, where she taught homeless refugees. At one point, there was a class of 96 of them, and she was 5'3" at the front, trying to teach them all English. She took my father, who has a louder voice than me, and is a big extrovert presence, and he just yelled what she was saying is pretty much how it worked. And they seemed to absolutely love it. They came for weeks and learned English, but I digress. That homeless community were very well looked after in that first wave. Of course, it's not as simple as that. It is challenging. There are layers of need on top of need. So there's often addiction, there's often family breakdown, there's often financial challenge. And we've tried to provide wraparound services with the third sector and the healthcare system and the local authority. And I think in the main, that has gone relatively well. We do have some big challenges, of course. This is the 1 year anniversary of our, or just about the 1 year anniversary of the horrible stabbing in a Glasgow hotel that had become a hostel for asylum seekers and refugees. And that was a horrible period for that community and the mental health challenges inside that community. So that problem is not done, not by any means, but it has shone a light on it. We are vaccinating that community. So we're going with vaccine to the street to find individuals and vaccinate them, and then trying to find them again, of course, 8 weeks later, which can be a bit of a problem. Prisons is also a fascinating study. Wave one, there were some pretty severe outbreaks in Scotland's big prisons. Wave two, and now much, much better controlled. I just spent a day in Berlin, which is Glasgow's big prison, with 1,100, 1,200 inmates. Sometimes 100 admissions a night. 100 people can come in one evening. And trying to do that in a COVID-safe way, you can imagine that can be challenging. And they may not be in for long, often young men on remand or very short sentences. So it's tough. I actually went to be on their radio station. So they have a prison radio show run by a prisoner who is on an apprenticeship, learning how to work the microphones and the sliders and the stuff. And I took questions from the prison community, from the prisoners themselves and the staff. It was a fantastic afternoon taking questions from them. Their principal concerns were the same as yours and mine. They were vaccination, family visits, when can I hug my kids? When can I? It was all exactly as you would expect. And we did our best to reassure them as best we can. We've redone the guidance more recently. So now the physical distancing that we've removed from private homes has also been removed from visiting areas. So they can now hug their families and see their kids a little bit more. It's been absolutely tragic to restrict all of those connections. My real passion for criminal justice comes from the fact I think it is a huge gap in our rebuilding and our renewal. And if we don't mend some of that, what will we call it? The revolving door of some of the young men, in particular in Glasgow and in Scotland more broadly, coming in and out of those institutions. The one good thing is I have a captive audience to vaccinate, so I can get them, but that's not really a reason to put them in prison. So I when this settles, I'm going to re-establish my interest in criminal justice. I'm speaking to the Justice Board, which is Scotland's kind of governance for justice, this Friday, in fact, because we're going to think about the next phase of safety and COVID.
Fantastic, thank you. And as a final question, I want to preface this by saying that a number of the comments and questions that we've had on the feed here have been wanting to say thank you and to say we really hope you're getting a break at some point soon, and to thank you for all you're doing. But the question I just wanted to ask was from a URC minister in Scotland, to say if you could go back and have Scotland do one thing differently since March 2020, what would it be?
I honestly don't know. I'm not trying to dodge it. It's a really, really difficult question. And when the public inquiry comes, public inquiries come, which may be my next decade of life, fortunately or unfortunately, I think there will be a lot of the decisions questioned. Of course, the obvious one is, should you have discharged people from care homes, from hospitals to care homes? That's an obvious scientific question to ask. And then the judgment question about politicians following advice or otherwise, or whatever happened. There'll be questions about financial support. There'll be questions about testing. There'll be questions about self-isolation. This sounds glib. I can tell you that every single day when the small group of us have got up, we've made decisions with the best of intentions based on that day's science. So when we told the First Minister to do X, Y, or Z, we did that with the best of intentions. Now, what we know now is very different. So we now know that a third of people are asymptomatic and can spread the disease. We now know what testing means, a little bit more, not fully. We now know a lot more about how the virus is spread. We know that what we did meant our hospitals didn't get overwhelmed like the northern Italian hospitals. But when we were in the position in March, when we saw the northern Italian hospitals being overwhelmed and people dying in the corridors, we had to move the vulnerable. And that's what we did. Now, if I could go back and not do that, then of course, I don't want people to suffer. I don't want people to have infection and people to die. But at the time, I didn't have the available knowledge I have now. And I think that's one of the toughest things in the media, in the inquiries, in the kind of sterile parliamentary committees, which I'm sure we're all going to go through from now for the next 5 or 6 years at least. There is a moment in time when you're faced with the decision, and politicians, I think, should be applauded for having to make those choices, whether you're Boris Johnson, Emmanuel Macron, or Nicola Sturgeon. There is a buck that stops with you, and you have to take all that advice you can and then make those really, really tricky choices. And people don't feel sorry for politicians, and I'm not asking them to feel sorry for me. These are big jobs, they're high stakes. We know what we're doing when we enter them, but it's not as straightforward sometimes as the headlines suggest.
Thank you. Thank you. One of the things that didn't appear on your list of leadership qualities was humility, which was another of the questions we had. And I think that your willingness to talk so honestly and with humility about what you've been facing over the last 15 months has been really superb and breathtaking. So thank you for that. I'm going to introduce Reverend Mark Slaney now. Mark is the chair of Methodist Church in Scotland, and he's going to respond to the lecture and to thank Professor Leitch.
Thank you, Rachel. Professor Leitch, Jason, if I may call you that, it's my job to offer thanks on our behalf to you this evening. So first of all, let me thank you for your time in what undoubtedly has been another trying day for you. So thank you for being willing and offering and committing yourself to spend time with us. And maybe you've got more work to do when you finish here. So I hope not to be too long, but thank you for that time. I want to thank you for sharing with us your global perspective and your frontline presence to give us the biggest possible picture and to help us begin to think of how that is applied in particular contexts. I want to thank you for your energy and your engagement at this time of night, still to be able to sit in front of a screen and present yourself with a level of energy that you appear to have, and the engagement, for example, with every question that's been asked, and to hear it and respond to it. So thank you for that. For your knowledge and your application of that knowledge. It's one thing to know something, it's another thing to be able to give advice that matters and to be able to apply it across the board to a variety of contexts and scenarios and sectors. So thank you for that. For your insight and your inspiration to us as people of faith, as we consider what it means for us, some of us to lead, but for us as communities to play our part. So thank you for your insight and your inspiration. Thank you for being persistent in your leadership and your message. Maybe you, more than us, had some idea how long this might play out when it started a year ago, March, and we were thinking in our heads, oh, it'll be 3 months and we'll be back to normal. And to be able to be persistent over that length of time, and that worn out at the same time and worn down, is impressive. It's impressive. So thank you for that. For your clarity and the complexity that you've presented to us. So to be able to say really clearly, here's what we know and here's what we don't know, and here's why that's really difficult. Life is, even for those of us of faith, we are beginning increasingly to learn that life is very rarely as black and white as we sometimes like it to be. So the challenge for us to be clear in what we believe and to deal with the complexities of life. Thank you for that. And your ability, as Rachel said, thank you for being honest with us, but also thank you for your fairness. So to hear you speak about what it means to lead as a politician, or as a clinical director, the things that we don't see behind the headlines. So thank you for all of that in your presentation to us. Thank you for listening and genuinely responding to the questions that we've asked of you. And then finally, Jason, when the Methodist, the UK Prime Minister said a week ago Monday that the restrictions weren't being eased as they'd hoped, and the Methodist Conference moved to being a hybrid occasion, and we rapidly reorganised ourselves, chairs of districts such as myself were asked to find out who was going to be attending on site and who was going to be attending online. And as I thought, as the chair for 2 districts, Scotland and Shetland, the whole nation, what my advice might be to my representatives, the first thing I did in my head was I said, what would Jason Leitch say? And rightly or wrongly, I heard him say, no, Mark, you don't have to go. You can do that from home. So thank you for being trustworthy, for me at least, and for keeping me in Scotland for another 9 days of my life when I could have been down there in Birmingham. On behalf of us all, Professor Leitch, thank you for your time, and thank you for everything that you've offered to us this evening.
That's very generous, Mark. Thank you so much for having me.
Thank you very much, Mark. Jason's lecture will be available on the Joint Public Issues Team website, where you can also sign up to the newsletter for information about forthcoming events. We've had a good run of Scottish people delivering great lectures recently. Many of you have been with us for the Gordon Brown lecture a couple of weeks ago, which will be available on the Methodist Church Walking with Micah webpage if you missed it. But if you've got suggestions for people you'd like to hear from in the coming year, possibly people who aren't Scottish, because we do listen to other people as well, do let me know by tweeting me or emailing me at lampard@methodistchurch.org.uk. So thank you again to Professor Leitch, Jason, for delivering the 2021 Beckly Lecture, and thank you to everyone for joining us this evening. I look forward to seeing you all next year. Thank you again, and good night to you all.